Welcome to this video. In this video, we will talk about antifungal agents. Now, in order for us to understand the mechanism of action of antifungal agents, we need to look at the structure of the fungus cell wall. Now, looking at this, let's picture this as the structure of the fungus cell. Here is the cell wall, here is the cell membrane, and here is the nucleus containing the DNA. So we have various classes of drug that we add on these places, okay, on these structures. First, we have the cell wall. The cell wall contains beta-D glucan. So the class of drug called echinocandins act on cell wall, inhibiting the synthesis of beta-D glucan. Come to the cell membrane. The cell membrane contains ergosterol. There are various drugs that tries to inhibit the synthesis of ergosterol. So if you look at this now, we have the pathway for the synthesis of ergosterol. So this is squalene. Squalene gets converted to lanosterol. Lanosterol gets converted to ergosterol. So squalene to lanosterol will require the enzyme called epoxidase enzyme. This epoxidase enzyme is inhibited by a drug called terbinafine. Okay, so we have squalene going to form lanosterol, inhibited by what? The enzyme is epoxidase, and that epoxidase enzyme is inhibited by terbinafine. Take note of that. The lanosterol will be converted to ergosterol, and the enzyme responsible for that is called demethylase enzyme. Demethylase is inhibited by azose. Okay, it's inhibited by azose. So you can see that from squalene to lanosterol to ergosterol, epoxidase is inhibited by terbinafine, demethylase is inhibited by azose. Now, one thing you will notice later on is that terbinafine is fungicidal, while azose is fungistatic. Okay, so you just put that at the back of your mind that terbinafine is fungicidal, it will kill the fungus, while azose is fungistatic. Okay, so that's one important thing to take note now. Now, these two drugs, terbinafine and azose, they inhibit the cell membrane. They inhibit the cell membrane synthesis. Another drug that also inhibits cell membrane but does not work on this pathway is called amphotericin B. So amphotericin B binds directly to the already formed ergosterol. Okay, it binds directly to the already formed ergosterol and form pores on the membrane, such that these pores will now lead to the leaking out of what substances. Substance will leak out of the cell, and that will lead to what cell death. Okay, so it means that amphotericin B is a bactericidal drug, because you can see it's causing pores on the cell membrane, so it will lead to the cell death. Okay, so now we can say that amphotericin B, azose, and terbinafine, they are all acting on what? On the cell membrane. They are all acting on the cell membrane. Okay, so how many drugs that we look at now? We've looked at one, we've looked at two, we've looked at three, we've looked at four. Okay, so take note of that. Then, so terbinafine, azose, and amphotericin B, they all act on the membrane. So moving now to the nucleus, there are two drugs acting on this nucleus level. There are two drugs that act on the nucleus level. The first one is 5-flucytosine, and the second one is griseofulvin. So we have 5-flucytosine and griseofulvin. These two drugs, they act on the nucleus. As we proceed, we will get to see their mechanism of action. Okay, now let's start with amphotericin B. Amphotericin B, from the last time we discussed it, we said what? It creates what? Pores on the membrane. It binds to ergosterol and create pores on the membrane, make the membrane to be leaky. Okay, and it is what? Fungicidal agent. It's a fungicidal drug. Now, what is the spectrum? What kind of fungus can it kill? What kind of fungus can it destroy? So it is a broad spectrum drug. It's a very broad spectrum drug. It kills all fungus except dermatophytes. And the reason why it does not kill dermatophyte is because it does not concentrate on the skin to a large extent. Okay, it does not concentrate on the skin. If not, it can also kill dermatophyte. Dermatophyte are on the skin, so amphotericin B does not concentrate on what, on the skin to a large extent, so it can't kill dermatophytes effectively. Okay, so it can kill all fungus but not dermatophyte, based on it does not concentrate on the skin to a large extent. How do you give amphotericin B? You give it by IV infusion. You don't give it orally, solely given as an IV infusion. This is one of the limitations of amphotericin B also, because imagine a drug that you can only give by IV infusion. It means anytime you want to give this drug, the patient must be in the hospital. Okay, so that is one limitation. So what are the side effects of giving amphotericin B? The most common side effect is what we call infusion reaction. As you are giving the drug, the patient will be having this infusion reaction, which are more like hypersensitivity reaction. So initially you will notice mild rash, there will be fever, there will be also anaphylactic reaction. Okay, so these three are called what? Infusion reaction. How do we tackle this infusion reaction? To tackle this infusion reaction, you can just give the patient antihistamines. Okay, antihistamine will help to neutralize these infusion reactions, because these infusion reactions are more of hypersensitivity reactions. Now, moving further, a more serious reaction is nephrotoxicity. Nephrotoxicity. Okay, apart from that infusion reaction, we also have what? Nephrotoxicity. Now, to counteract nephrotoxicity, we develop a new or a well-packaged amphotericin B that is called liposomal amphotericin B. So liposomal amphotericin B now has less nephrotoxicity. It has what? Less nephrotoxicity. So, but the only drawback is that what? It is expensive. It is expensive. Okay, so we've seen that amphotericin B has a very common side effect that is called infusion reaction, where there will be mild rash, fever, anaphylaxis. Then we give antihistamine for that. Okay, while the most serious side effect is what we call nephrotoxicity, and for the nephrotoxicity we come up with what we call liposomal amphotericin B, which is more like a well packaged an amphotericin B that is packaged in a lipid. Okay, that is surrounded by lipid molecules. Okay, so this one is more expensive. Other side effects include hypokalemia. Then it can also cause mild bone marrow suppression, and whenever there's bone marrow suppression, what will come about will be anemia. So these are the side effects of amphotericin B. What do we use them for now? Nowadays, the use has been limited because of two main reasons. One is the high nephrotoxicity. So because even that liposomal is expensive, so the one that is common is the amphotericin B. So we try to shy away from it, and also because of the intravenous route, the patient must be in the hospital. Because of these two reasons, the use of amphotericin B has been limited. If not, amphotericin B is effective on all fungus. Okay, like I said earlier, except dermatophyte, because it does not concentrate on the skin. Now, there are some places we still use them. It is the drug of choice for mucormycosis, for mucor infection. So mucor infection is an infection that is characterized by infection of the nasal sinus. Okay, and you will start seeing black discharge, okay, from that nasal sinus. That is what we call mucormycosis. It is classic. You all see the image. The nasal sinus is infected such that you are seeing black discharge, okay, from it. So apart from using amphotericin B for the treatment of mucormycosis, there is a particular azole that is one of the latest azole that is called posaconazole. Posaconazole can be used to treat mucor also. Okay, can be used to treat mucormycosis, and also you can give the ferrazinrox. This is a ion chelator. Okay, can also be used. But take note that what normally azoles they don't treat mucor, but this new one, posaconazole, can treat what? Mucor. Also, it is also amphotericin B is also the drug of choice for cryptococcal meningitis. Take note of this, cryptococcal meningitis. So when we diagnose the patient with cryptococcal meningitis, we start the patient on IV amphotericin B plus oral 5-flucytosine. Okay, we'll get to know like 5-flucytosine shortly, but just know that when a patient has cryptococcal meningitis, we start the patient on amphotericin B, then add 5-flucytosine. Amphotericin B, like I said, is given IV. 5-flucytosine is given what? Orally. So once the patient has become stable, you will now switch to oral fluconazole. Oral fluconazole, this one is an azole, okay? So we'll look at them very shortly. Now, it's also the drug of choice for any life-threatening infection. So once a patient's life is being threatened by a fungus infection, we don't care anymore because we just give the amphotericin B regardless of the nephrotoxicity, because now it has been deteriorated to a large extent. You get. Then it is also the drug of choice for Kala-Azar. Kala-Azar is a non-fungus infection, actually, also called visceral leishmaniasis. Okay, visceral leishmaniasis. So to treat this one, we give it. It's given as a single daily infection. Just give it once. Okay, just that day. That's when you give it. So you give the IV infusion for just that one day. So the way you calculate it is that it is given as 10 milligram per kg. So depending on the kg of the patient, that's how you administer. Okay, 10 milligram per kg. So you calculate it. If the patient is 70 kg, 10 times 70, meaning you are giving around 700 milligram. Okay, and you usually give it for over 8 hours. Okay, so now we've seen that amphotericin B uses are now limited to these 4 major uses. Okay, these 4 major uses because of the adverse effect and everything. So the first one, where it is drug of choice, is mucormycosis, but I explained to you that posaconazole can also be used. Okay, then it is the drug of choice for cryptococcal meningitis. Here we combine it with 5-flucytosine given orally. Then once the patient is stable, we switch to fluconazole. Then it's also a drug of choice for any life-threatening infection, any life-threatening fungus infection. And then Kala-Azar is the drug of choice. We give it as an IV infusion, as I've said earlier, for 8 hours, 10 milligram per kg. Now let's come to 5-flucytosine. 5-flucytosine, this drug, like I said, it works in the DNA. It works in the DNA. It's one of the drugs that work in the DNA. Amphotericin B works in the membrane. It binds to ergosterol and cause pores. But this one we are discussing now, this one works in the DNA. Okay, so it undergoes deamination reaction in order for it to become active. So 5-flucytosine will need to be deaminated to form 5-fluuracil. It is this 5-fluuracil that inhibits DNA synthesis, and the enzyme that does this deamination, which is this deaminase enzyme, is found only in the fungus cell. So only those cells that are infected by the fungus can actually convert 5-flucytosine to 5-fluuracil. Okay, so in order to cause inhibition of DNA synthesis, take note of that. So it's only found in the fungus cell. As a side effect, based on saying it's inhibiting DNA synthesis, you will notice bone marrow suppression as a side effect, meaning anemia will come in. Okay, anemia will come in. Okay, now where do we use this one? I've said it earlier. Together with amphotericin B, we use it for the treatment of cryptococcal meningitis. For the treatment of what? Cryptococcal meningitis. So they have a synergistic effect in such a way that amphotericin B will destroy the membrane, then 5-flucytosine can easily enter inside and target the nucleus. So they have a synergistic effect. Now let's now come to azoles. Now, like I said earlier, take note that azoles are fungistatic. They don't kill the fungus. Azoles are what? Fungistatic. Which enzyme do they inhibit? They inhibit lanosterol demethylase. You know, this is the enzyme that will convert lanosterol to ergosterol. Okay, the last enzyme there that will convert lanosterol to ergosterol. The first one was squalene to lanosterol. That one was what? Epoxidase enzyme. But lanosterol to ergosterol is done by demethylase. We demethylate it. Okay, now that is for that. So take note that you don't combine azoles with amphotericin B. Both of them are acting on the membrane, so combining them will not really give any beneficial effect. Okay, so you don't combine them. It is contraindicated to combine azoles and amphotericin B. Amphotericin B is working on already formed ergosterol. Azoles is inhibiting the synthesis of ergosterol. So if you inhibit the synthesis of ergosterol, amphotericin B will not have anything to work on. Okay, so we don't combine them based on both of them are all acting on membrane level. So you don't combine them. So ergosterol, sorry, azoles, they have a wide, broad spectrum fungus are the key, including dermatophyte. Remember we said that amphotericin B kills a wide range of fungus except dermatophyte because it does not concentrate on the skin. But now azoles, they have the ability to concentrate on the skin, so they are used for a wide range of fungus. Okay, so however, take note that mucor is naturally resistant to azoles except this latest azole called posaconazole. So posaconazole is the only azole currently now that can kill mucor. If not, mucor before now were resistant. They even till now they are resistant to azoles except this posaconazole. Okay, so as a common side effect of all azole is liver toxicity. One of their common side effects. You are giving the patient azoles. One of their common side effects is liver toxicity because they tends to elevate the liver enzymes, your AST, your ALT, they elevate them. Those are signs of liver damage. Okay, so take note of that. Now we have various type of azoles, starting with ketoconazole. We start with ketoconazole. So ketoconazole use now has been drastically limited based on adverse effect, based on toxicity. These days we use it only as topical uses. Okay, where we use it in shampoo, we use it in creams, we use it in powder. Even currently now, ketoconazole has been banned. The oral ketoconazole has been banned by NAFDAC. Okay, so for the systemic use has been stopped, and the reason for that include it has anti-androgenic activity. It can block androgen, and that will lead to gynecomastia in male. This is one. Then it also inhibits the synthesis of steroid hormone, and that is adrenal steroid, which are steroid hormone. This adrenal steroid hormone. If those hormones are inhibited, it will lead to a lot of metabolic disturbances, both in glucose and other metabolites. Okay, even regulation of blood pressure will be affected because your aldosterone will not be synthesized properly. Okay, so it inhibits the synthesis of adrenal steroids. Then this one is very, very important. It's a very, very, very strong inhibitor of cytochrome 3A4. Note that the cytochrome 3A4 metabolizes close to 60% or more than 60% of drugs. So if you are inhibiting this enzyme, it means that there will be a lot of drug-drug reaction. A lot of drug-drug reaction will occur. Okay, many drugs will have toxicity. So this is one of the major reasons. Then it does not cross the CSF properly. So certain all those fungus that have affected the CNS, it can't treat them. Okay, so because of this side effect, this anti-androgenic blocks synthesis of adrenal steroids, very strong CYP3 for inhibitor, and poor CSF penetration, will now develop fluconazole. So fluconazole has a lot of advantages. It has a lot of advantages. It does not block, it does not have any androgenic effect, meaning that it will not cause gynecomastia. It has no action on adrenal gland. It has minimal cytochrome P450 inhibition. It has excellent CSF penetration, and we can give it orally also. Okay, we can also, it has a good oral bioavailability. Okay, so for this now, fluconazole is the drug of choice for three C's. Candida, coccidioidomycosis, cryptococcosis. For this cryptococcosis, it is the one that is pneumonia. You know, when cryptococcus enters the body, it enters through the respiratory system. It is when it has complicated, that's when it will cause cryptococcal meningitis. But that initial phase where it causes pneumonia, the drug of choice is fluconazole. Okay, together with candida infection and coccidioidomycosis. Okay, so take note of that. Candida, coccidioidomycosis, and cryptococcus. Okay, now We will now talk about itraconazole. Itraconazole is the next one that was developed. So this one has a wider antifungal spectrum and than fluconazole. It's more better than fluconazole. It has a wider range. So it is a drug of choice for all dermatophytes. All dermatophytes. It kills many of the dermatophytes. The only exception for that is it can also work on onychomycosis, but it is not a drug of choice for onychomycosis. So for onychomycosis, we use terbinafine. Okay, we use terbinafine. We will come to realize terbinafine shortly. Then also for this particular tinea capitis, we use griseofulvin. Okay, we use griseofulvin. So take note of that. Itraconazole has a wider range of spectrum. It can kill all dermatophytes except these two, onychomycosis and tinea capitis. It can kill them too, but it's not the drug of choice for them. Okay, then it's also the drug of choice for majority of the deep fungus, histoplasmosis, blastomycosis, majority of those systemic fungus. The only one where it is not the drug of choice is in mucormycosis. Remember we said in mucormycosis we use amphotericin B. Okay, we use amphotericin B. We can also use posaconazole, which is the new azole. Okay, then also for coccidiomycosis, which is one of the 3Cs, the drug of choice there was fluconazole. Okay, so take note of that. Both this one is also a deep fungus. Okay, so it's also a deep fungus. Mucormycosis is more of an opportunistic fungus. Now let's now come to some newer azoles that were formed. Newer azoles include voriconazole, which is a drug of choice for invasive aspergillosis. Side effect: V for visual, so it causes visual disturbances. Then posaconazole, I've been saying this one. This is the latest azole, the broadest azole, including mucor. Okay, so you can kill mucor. Then talk about terbinafine. Terbinafine now, the mechanism of action of terbinafine is that it inhibits squalene epoxidase enzyme. It inhibits squalene epoxidase enzyme, thereby disrupting the cell membrane. You know, squalene epoxidase is the first enzyme in that pathway, so it is fungicidal. In terms of its antifungal spectrum, it is only limited to dermatophytes. So dermatophytes are the fungus that affect skin, hair, and nails. Okay, it's only limited to dermatophytes. So how do we give it? We can give it topically, we can give it orally. So it is a drug of choice for onychomycosis. We've seen it earlier on where I said for onychomycosis we give terbinafine. So terbinafine is the drug of choice for onychomycosis. And terbinafine, how does it work? It works by inhibiting membrane synthesis. It inhibits membrane synthesis. Okay, it inhibits membrane synthesis. The reason why this one is fungicidal is because this squalene that we accumulate, squalene can destroy the cell membrane. If it accumulates, can destroy the cell membrane. Unlike azoles are fungistatic, but terbinafine that still work on that same pathway is fungicidal. We want to take note of that. So terbinafine is the drug of choice for onychomycosis. If you give it, we give it as 1 tablet daily for 3 months. It is more effective than fluconazole or the other azoles. Okay, it is best for onychomycosis. So remember, it's best for onychomycosis. Other newer agents we use to treat onychomycosis include efinaconazole and tavaborole. Efinaconazole and tavaborole. Okay, take note of these two, efinaconazole and tavaborole. All right. Now another drug in the list is griseofulvin. Griseofulvin, this one, it acts on the DNA level. It inhibits this one together with 5-flucytosine. They are the ones that act on the DNA level. So it inhibits mitotic spindle formation. Thereby disrupting them, leading to thereby inhibiting fungal division. You know, when cells want to divide, they will form mitotic spindles. So griseofulvin inhibit what? Mitotic spindle. So again, its antifungal spectrum is limited to dermatophyte only. It only work on dermatophyte, just like terbinafine, just that terbinafine has a different mechanism of action, griseofulvin has a different mechanism of action. Okay, so in terms of route, we give it orally, so it has high affinity for keratin. Okay, you can see that we don't give you don't give griseofulvin, though it's acting on only dermatophyte, but you can't give it topically. We only give it orally. It has a high affinity. If you take it orally, it has a high affinity for keratin containing tissues, again, which are the skin, hair, and nails. Okay, so, and again, this drug is static, is bacteriostatic. Okay, is bacteriostatic. So patient will need to take the drug for a long time. We need to take the drug for a long time before they can get cured of that dermatophyte infection. We need to take the drug for a long time, and many fungus have developed resistance to this griseofulvin. Many fungus have developed resistance to this griseofulvin. That's why we use it these days only for tinea capitis, because it's still effective for tinea capitis. Okay, so it is the drug of choice for tinea capitis, griseofulvin. Take note of that. Griseofulvin, fungistatic, inhibit mitotic spindle, thereby preventing cell division. Okay, then its antifungal spectrum is limited to dermatophyte. Though it kills dermatophyte, we don't give it topically, we give it orally. It has high affinity for keratin tissues, skin, hair, and nails. Okay, so take note of that. This is drug of choice for tinea capitis. Lastly, we come to drugs that inhibit cell wall, which are your echinocandins. So echinocandins will inhibit beta-glucan synthase. Thereby disrupt cell wall synthesis. So examples of such drug include caspofungin, anidulafungin, and micafungin. Caspofungin, anidulafungin, and micafungin. Now, we use them for resistance cases of candida and aspergillosis. Those are if you are, we said the drug of choice for candida was fluconazole. Okay, then the drug of choice for aspergillosis was voriconazole. So in those cases where you will notice that those azoles are not working for either candida or aspergillosis, then you can deploy your echinocandins. So we have caspofungin, anidulafungin, micafungin. They are all used for resistant cases. So you can see C starting with caspofungin, so that stands for candida. Then caspo, you can see as there again, that is aspergillosis, just to remember it. Okay, so that is for that. Now let's now come to a common infection that is called tinea versicolor. How do you treat tinea versicolor? First of all, you need to know that tinea versicolor is a condition that is characterized by hypopigmented lesions on the most superficial layer of the skin. Okay, hypopigmented lesions. It is non-pleuritic. Okay, so we give both topical agent and oral agent for this. So the topical antifungal we give include ketoconazole. We can give it topically. We can give selenium sulfide. We can also give cyclopyroxolamine. We can give this sticky drug for the topically for the treatment of tinea versicolor. So we give them as shampoos and lotion to rub it on the skin. Then also you can give oral fluconazole for the treatment of this tinea versicolor. Alright, with this now we've come to the end of this lecture. I hope you're able to get some important things from this lecture, and we urge you to click the subscribe button and give us a like. Thank you very much.